Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about ovarian hyperstimulation syndrome. So what we want to discuss today, the definition, epidemiology, etiology, pathophysiology, clinical features, how to diagnose, and classification and management. So what is the definition of ovarian hyperstimulation syndrome? It is an exaggerated response to ovulation induction therapy. The ovarian hyperstimulation syndrome is typically associated with exogenous gonadotropin stimulation and is only rarely observed with use of other agents like oral clomiphene citrate or with gonadotropin releasing hormone. This picture shows you TVS case with ovarian hyperstimulation syndrome. As you see, multiple follicles appear in the picture. Okay, this syndrome is self-limiting, usually resolved spontaneously within several days, but may persist for longer duration, particularly in conception cycle. So if this syndrome happen, ovarian hyperstimulation happen, and the pregnancy occur in this cycle, this is increase the severity of the condition, make it more prolonged, and maybe change it from mild to severe. The syndrome has a broad spectrum of clinical manifestation from mild illness, needing only just careful observation and some medications, to severe disease requiring hospitalization and maybe ICU admission. As you see in this picture, this is another case with CT scan, ovarian hyperstimulation syndrome. This is post ovaries with multiple follicles, and this is the uterus. What about the epidemiology? In a setting of IVF, the overall incidence of moderate and severe ovarian hyperstimulation syndrome 3 to 6% and 0.1 to 2% respectively. So the moderate cases are higher percent, 3 to 6%, while the severe cases 0.1 to 2%. Okay, this is in cases with IVF, with stimulation, with gonadotropin. But what if we are using oral clomiphene citrate? Rarely to occur. Severe cases are very rare with clomiphene citrate, but mild cases can happen with it. In spontaneous pregnancy, there is reported cases with hyperstimulation syndrome. And this may explain the theory that there is increased sensitivity of FSH receptors in the ovary. This is the cause of occurrence of spontaneous hyperstimulation syndrome without ovarian stimulation. Although the most severe form of ovarian hyperstimulation syndrome is rare, it represents an iatrogenic complication with a potentially fatal outcome in young women undergoing fertility treatment. And the clinician who prescribe ovulation-inducing agents must be prepared to recognize and manage ovarian hyperstimulation syndrome. What are the risk factors? PCOS is a risk factor, young age, low body weight, higher doses of exogenous gonadotropins, previous episode of ovarian hyperstimulation syndrome, high absolute or rapidly rising serum estradiol levels. All these are risk factors. What is the etiology? As we said, this syndrome is a serious complication of controlled ovarian hyperstimulation, especially with assisted reproductive technology in IVF and eggs procedures, because you are using large amount of gonadotropin as a stimulant to the ovary. So these patients, this woman, are liable for occurrence of this complication and its hazards. It occurs when the ovaries are hyperstimulated, enlarged with the use of gonadotropin hormone, or in rare cases there is increased sensitivity to FSH receptors. This results in, at the end, shift of fluid serum rich in protein from intravascular space to the third space like peritoneal cavity. In its severe form, it may be life-threatening because it can cause venous or arterial thromboembolic events. So, thrombosis can happen in both veins and the arteries. You should take care about this point. It's important. And maybe stroke, loss of perfusion of an extremity happen, okay, with thrombosis in arterial system. We have two clinical forms, early onset form and the late onset form. Early onset, which happen in the first 8 days after exogenous HCG administration. You give the patient HCG, then the syndrome developed within 8 days. So this is the early onset form. What about the late onset form? It occurs in 9 or more days after HCG administration. So it is related to pregnancy-induced HCG production. What about the pathophysiology? The most important to be known that there is increase in capillary permeability with shift of fluid rich in protein from intravascular space to third space compartment like peritoneal cavity. That's why there is ascites. You can look to this picture. This is the ovary stimulated with gonadotropin, multiple follicles present, production of vascular endothelial growth factor and renin angiotensin system leads to increased capillary permeability. So vascular permeability is increased, shift of serum from intravascular and the large amount of fluid from intravascular to be shifted to the third space. This third space, the peritoneal cavity, leads to ascites, and through the thoracic duct, the fluid go to the pleura, causing pleural effusion. So there is hydrothorax following ascites, and also maybe pericardial effusion later on. Okay. On the other side, when the fluid shifted from intravascular to extravascular, there is hypovolemia, and this hypovolemia will cause hypotension and will cause decreased organ perfusion, especially the kidneys and the liver. So there is renal impairment in ovarian hyperstimulation syndrome, and also hepatic affection with elevated liver enzymes. Also, with the hypovolemia, there is hemoconcentration, elevated hematocrit, and hypercoagulability, which leads to thromboembolic events. This is the pathophysiology simply. As you see in this picture, this is the ovary stimulated with HCG trigger, renin-angiotensin system, and vascular endothelial growth factors released, affecting the vascular system, increasing the permeability of fluid, leading to the ascites and pleural effusion and the hemoconcentration and increased risk of thromboembolism and decrease organ perfusion like kidney and the liver. Vascular endothelial growth factor is an angiogenic cytokine, potent stimulator of the vascular endothelium, and appears to play an integral role in follicular growth, corpus luteum function, and the ovarian angiogenesis. It was found that the vascular endothelial growth factors levels correlate with the severity of ovarian hyperstimulation syndrome. Also, we should know that HCG increase vascular endothelial growth factor expression in human granulosa cell and raises serum vascular endothelial growth factor concentration. That's why this syndrome is related to giving HCG to the patient to induce maturity of the follicle and induce ovulation. So the cause here that HCG increase vascular endothelial growth factor expression, and this has an important role in the pathophysiology of ovarian hyperstimulation syndrome. Other factors may be related to the vascular endothelial growth factor directly or indirectly, like angiotensin 2, insulin-like growth factor, interleukin 1b, interleukin 6, platelet-derived growth factor, transforming growth factors. All these may be included in the pathophysiology of ovarian hyperstimulation syndrome. The risk is increased with the number of growing follicles. So the cycle with larger number of follicles at risk of hyperstimulation syndrome. That's why polycystic ovary is a risk factor for ovarian hyperstimulation syndrome. Also, risk increase when higher or repeated doses of exogenous HCG are administered in superovulation and ART cycle. So if you give the patient repeated doses of HCG, not just only for induction of ovulation, but also for maintaining the corpus luteum, the luteal phase, this may be hazardous due to exposure of large amount of HCG, which inducing the ovarian hyperstimulation syndrome. So it's better to give the patient, especially the high risk, progesterone to maintain the luteal phase or to do the support for luteal phase rather than to give the patient HCG. So in risky cases, don't give HCG to support luteal phase, but give progesterone. What are the clinical features? The clinical features may be mild, just mild nausea, vomiting, diarrhea, abdominal distension, or become more worse or prolonged with time and progress to be severe with more abdominal distension, with development of ascites, with enlargement of the ovary, with severity of the vomiting and the diarrhea and the abdominal pain, with rapid increase in body weight, with tense ascites, with hemodynamic instability like hypotension, tachycardia. So, hypotension results from extravasation of protein-rich fluid and the contraction of the vascular volume. Also, we can find oliguria in some patients due to reduced renal perfusion, as I mentioned before, because there is hypovolemia, because amount of fluid passed from the intravascular compartment to the third space is high, so there is decrease in organ perfusion causing renal impairment and also liver impairment. Pulmonary compromise from an elevated diaphragm due to ascites or due to hydrothorax. Also, risk of thromboembolism in severe cases is increased due to hemoconcentration, diminished peripheral blood flow, and inactivity due to abdominal distension and pain, because the patient may stay in bed for a long time because of the abdominal pain and distension. And this is dangerous for thromboembolism. What is the life-threatening complication? Renal failure, respiratory distress syndrome, hemorrhage from ovarian rupture, or ruptured cyst, and thromboembolism and hyperkalemia. Diagnosis: from history, you should ask about the time of onset of symptoms relative to trigger, medication used to trigger. You use the HCG or GnRH agonist. What is the number of follicles on final monitoring scan? Number of eggs collected, where embryos replaced, and how many? Is there any signs of polycystic ovary syndrome? Then ask about the symptoms: the abdominal bloating, nausea and vomiting, abdominal pain, breathlessness or inability to lie flat, leg swelling and vulval swelling, reduced urine output, or any symptoms and sign of thrombosis, venous or arterial thrombosis. What about examination? General vital signs like pulse, respiratory rate, blood pressure, and the body weight is very important, because rapid increase in body weight indicating the severity of the condition. Assess for dehydration: is the patient is dehydrated or not? Assess for edema, valval edema, sacral edema, and of course pedal edema. What about abdominal examination? What is very important, as you see in the picture, measuring of the abdominal girth. When you measure the abdominal girth, try it at the level of the umbilicus, at the center. Then assess for ascites, any palpable mass, because the bilateral enlarged ovary can be felt abdominal, and any signs of Britanism. Respiratory examination: assess for pleural effusion, pneumonia, and pulmonary edema. The investigation needed, like CBC, C-reactive protein, of course, hematocrit. I expect hemoconcentration, of course, and this hematocrit increase with the severity of the condition. Urea and electrolytes, expected to find in severe cases hyponatremia and hyperkalemia, and the hypoosmolarity. Liver function test for elevated liver enzyme and reduce the albumin. Coagulation profile is important. Expected in severe cases elevated fibrinogen and reduced antithrombin. HCG is important to determine outcome of treatment cycle, is there is pregnancy or not. Ultrasound scan for ovarian size, for pelvic and abdominal free fluid. Also, you may need to do Doppler ultrasound if you suspect torsion in adnexy, and this patient is at high risk for torsion because the ovaries are enlarged, and torsion may happen as a complication. Some other investigation needed in certain cases and very special cases: arterial blood gases, D-dimer, ECG and the echocardiogram, chest X-ray, CT, pulmonary angiogram in case of suspected pulmonary embolism, or ventilation perfusion scan. The classification of ovarian hyperstimulation syndrome may be mild, moderate, severe, and the critical one. The mild, there is just abdominal bloating, mild abdominal pain, and the ovarian size less than squared 8 centimeters. Moderate ovarian hyperstimulation syndrome, there is more pain, moderate pain, nausea with or without vomiting. There is ultrasound evidence of ascites. Ovarian size range between 8 to 12 square centimeter. In severe cases, there is clinical ascites evident and may be associated with pleural effusion also. There is oliguria, the amount of urine per day is less than 300 milli. Hematocrit more than 45. Hyponatremia, sodium less than 135. Hyperkalemia, potassium more than 5 millimole. Hypoproteinemia, decreased serum albumin, and the ovarian size more than 12 square centimeter. What about the critical ovarian hyperstimulation syndrome? There is tense ascites, large hydrothorax, hematocrit more than 55, white cell count more than 25,000, oliguria or anuria, evidence of thromboembolism, acute respiratory distress syndrome, and these cases need ICU admission, of course, and the life-threatening. What about the management? The management may be an outpatient management or hospitalized management. So, outpatient management is suitable for mild or moderate cases and rarely in selected cases with severe ovarian hyperstimulation syndrome. Treatment usually require only oral analgesic like paracetamol or opiates, but don't give the patient non-steroidal anti-inflammatory drugs because it may hurt the kidneys, may compromise the renal function. So give paracetamol or opiates more suitable as a painkiller. Counsel your patient about the symptoms and the signs of progressing illness. Instruct the patient to avoid intercourse because it may be painful, and also it is hazardous because it may cause ovarian cyst rupture. Treatment of worsening ovarian hyperstimulation syndrome require antiemetic and more potent analgesic. Most patients still can be effectively managed and monitored on an outpatient basis, but they require more careful evaluation, including frequent physical and ultrasound examination to detect increasing ascites, they should do daily weight measurement, serial lab determination of hematocrit, electrolyte, and the serum creatinine. This is very important. Paracentesis of acidic fluid can be carried in outpatient base, whether abdominal or transvaginal, under ultrasound guidance. Careful monitoring is essential and should include at least daily communication, if not examination, to ensure that the progression to more severe disease is promptly recognized. So, in some worsening cases and still treated as an outpatient case, it needs close monitoring. Close monitoring, very important. What is the recommendation for the outpatient management of persistent and worsening ovarian hyperstimulation syndrome? Oral fluid intake maintained at no less than 1 liter per day. Any of the commercially available electrolyte supplemented drinks is preferable to other beverages. Strenuous physical activity should be avoided. Any increased activity than usual should be avoided, but not advise the patient to complete rest in bed, because rest in bed will precipitate to thromboembolism. So the patient move, but avoid excessive physical activity. Patient may be advised to take low molecular weight heparin as a thromboprophylaxis daily, especially if she carries risk factors. Weight should be recorded daily, and weight gain equal to or more than 2 pounds per day or decreasing urinary frequency should prompt repeated physical examination, and must do ultrasound and the lab evaluation, including serum creatinine, electrolytes, sodium and potassium, and hematocrit percentage. Pregnant patient with ovarian hyperstimulation syndrome must be monitored very closely, because risk of progressing to severe disease is particularly high for those further stimulated by rapidly rising serum concentration of HCG. In ART cycle, it may be necessary to consider cryopreserving of all embryos and deferring transfer to a subsequent cycle after the symptoms have completely resolved. This approach may reduce the risk of developing severe ovarian hyperstimulation syndrome without a marked decrease in pregnancy rate per cycle. Hospitalization. Hospital admission should be considered for whom? For women who are unable to maintain adequate fluid intake due to nausea, or to achieve satisfactory pain control, or that whom has a sign of worsening ovarian hyperstimulation syndrome despite the outpatient intervention, or patients who are unable to attend for regular outpatient follow-up, or patients have a critical ovarian hyperstimulation syndrome. So, must be admitted to the hospital. And the hospitalization considered when one or more of the following are present: severe oliguria or anuria, severe abdominal pain, intractable nausea and vomiting, tense ascites, dyspnea and tachypnea, hypotension, dizziness, syncopal attacks, elevated liver enzymes, hemoconcentration, hematocrit more than 45, leukocytosis more than 15,000, hyponatremia and hyperkalemia, decrease creatinine clearance less than 50 milli per minute, and increase serum creatinine more than 1.2. Vital signs should be measured every 2 to 8 hours according to the clinical status. In the hospital, when you are monitoring the patient, vital signs every 2 to 8 hours according to the condition of the case. Weight every day, weight measurement. Complete physical examination daily, and be careful not to do by manual examination because you may induce rupture ovarian cyst and cause internal hemorrhage, which is an emergency situation and the critical case. Abdominal circumference at the navel, at the level of the umbilicus, recorded daily. Monitoring of fluid intake and output daily. Ultrasound examination for ovarian size and ascites, repeated as necessary to guide the management or the paracentesis. Chest X-ray and the echocardiogram when pleural or pericardial effusion is suspected. Pulse oximetry, especially for patients with respiratory symptoms. CBC daily is important. Electrolytes daily, sodium and potassium. Serum creatinine and the creatinine clearance should be done as necessary, day after day, or sometimes daily. Liver enzymes repeated as necessary also. Careful and frequent re-evaluation of the hospitalized patient with ovarian hyperstimulation syndrome is essential. Complaint of increased abdominal pain and distension demand immediate attention, remaining mindful that pain and ascites can easily mask ovarian rupture and acute intra-abdominal hemorrhage. So you may suspect the patient has abdominal pain from just the ascites, while the patient is complicated with ovarian cyst rupture and internal hemorrhage. So be careful about this point. Serial clinical and lab evaluation is important. Multidisciplinary assistance is important, and the ICU should be available. What about fluid management? In hospitalized patients require intravenous fluid management to address the acute need for volume expansion. You remember when we said there is hypovolemia, so I want to compensate for that. But remember, what is very important, that there is increased vascular permeability, okay, due to increased vascular endothelial growth factor and other factors causing increased permeability that accompany ovarian hyperstimulation syndrome. So when you give intravenous fluid, it should be wise, okay? Renal and pulmonary function must be carefully monitored. Strict monitoring of fluid intake and urine output is essential until symptoms improve or diuresis begin. And this is a very important sign, by the way. Beginning of diuresis is a good sign that the patient is improving. Oral fluid intake should be carefully recorded. Fluid replacement by the oral route guided by source, and this is considered the most physiological approach to correcting intravascular dehydration. But what if the patient cannot swallow oral fluid because of severe nausea and vomiting? Intravenous fluid is a choice. Rapid initial hydration, bolus intravenous fluid with 500 to 1000 milliliter. Thereafter, fluid should be administered wisely in the volume necessary to maintain adequate urine output more than 20 to 30 milli per hour and reverse the hemoconcentration. So my target is to improve the hypovolemia and to improve the hemoconcentration and increase organ perfusion like kidney and so on. 5% dextrose in normal saline, as in this picture, is preferable to lactated Ringer solution, given the tendency to hyponatremia, correction of hypovolemia, hypotension, and oliguria has the highest priority, accepting that fluid administration may contribute to the accumulation of ascites. Be careful about this. Albumin, 25% in a dose of 50 to 100 gram, infused over 4 hours. And you can repeat it after 12-hour interval as necessary. Is an effective plasma expander when infusion of normal saline fail to achieve or maintain hemodynamic stability and adequate urine output. In general, albumin is the preferred plasma expander, although other like mannitol, fresh frozen plasma may be used. Dextran has been associated with the development of adult respiratory syndrome and is best to be avoided. So avoid use of dextran completely. Treatment with diuretic is the rule of diuretic. Furosemide 20 milligram intravenous may be considered after an adequate intravascular volume has been recorded and the hematocrit should be less than 38. Otherwise, you cannot give furosemide. So you should be sure that there is adequate intravascular volume and the hematocrit is less than 38. Premature use of diuretic will aggravate hypovolemia and the hemoconcentration and increase risk of thromboembolism. So be wise when you are using diuretics. Intravenous fluid administration should be sharply curtailed and the oral fluid intake increased when there is evidence that symptoms is resolving, generally heralded by improving symptoms and the onset of breast dialysis. So you shift from intravenous fluid to oral fluid after improving of the symptoms and after occurrence of dialysis. This is a sign of improvement, so you can here shift from intravenous fluid to oral fluid. What about hyperkalemia? How can you manage hyperkalemia? Hyperkalemia is associated with risk of arrhythmia. Acute management involves treatment that move potassium into the intracellular. You know that the treatment is to stimulate the entrance of potassium inside the cell, intracellular, by using glucose and the insulin and bicarbonate and albuterol. Or protect the heart from the effects of elevated potassium levels by calcium gluconate. Electrocardiographic manifestations of hyperkalemia, you will see it right now. This is a normal ECG. This is the ECG of hyperkalemia. As you see here, there is big T wave, a sign of hyperkalemia. With more hyperkalemia, there is prolonged BR interval and wide QRS here and the big T wave. With more serious cases, loss of B wave and sinusoidal wave as in this picture. What is the indication of paracentesis? Severe abdominal distension and severe abdominal pain secondary to ascites, affecting respiration, shortness of breath, respiratory compromise secondary to ascites, and increased intra-abdominal pressure. Also in cases with oliguria, especially if oliguria, despite adequate volume replacement, secondary to increased abdominal pressure causing reduced renal perfusion. because with increased intra-abdominal pressure, there is reduced renal perfusion. So I wanted to decrease the intra-abdominal pressure, so I wanted to do paracentesis. Through vaginal or abdominal route, intravenous colloid therapy should be considered for women in whom large volume of fluid was removed by paracentesis. At the same moment, give the patient intravenous colloid. Of course, you do paracentesis guided by ultrasound. There is no optimum amount of fluid to be aspirated, okay? And you should be wise during doing paracentesis as regard the amount and not too fast in withdrawal of fluid from the peritoneal cavity. Nevertheless, it is prudent to remove fluid at a deliberate pace until the desired effect is achieved, while carefully monitoring the patient response. You may want to repeat the paracentesis many times. It's okay, no problem. Paracentesis will generally be effective in resolving hydrothorax, and thoracentesis may be reserved for those with bilateral or severe pleural effusion. So, just paracentesis will improve mild cases of pleural effusion. So, I'm not in need for thoracentesis. But in severe pleural effusion and bilateral, I may need thoracentesis. What about thromboembolism? Should I give the patient prophylactic measurement? Yes. Use elastic stocking. Use heparin 5000 subcutaneous every 12 hours. Use pneumatic compression device as you see in the picture. Intermittent pneumatic compression device, especially in those bedridden for a long time. Intensive care may be required for management of thromboembolism, renal failure, or pulmonary compromise that doesn't respond to supportive case and paracentesis. Renal failure will often respond to low dose of dopamine therapy, 0.18 milligram per kilogram per hour, that will dilate renal vessels and increase renal blood flow. Invasive monitoring of central venous pressure or pulmonary capillary wedge pressure and even short-term dialysis may be required. Pulmonary intensive care may involve oxygen supplementation, thoracentesis, and assisted ventilation when more conservative measures fail. Thromboprophylaxis should be considered at least until the end of the first trimester. But in general, thromboprophylaxis depend on the risk factors. So if the patient carry risk factor like thrombophilia and so on, so you can continue anticoagulant until proper time. But we are talking about cases without risk factors. If she became pregnant after ART in ovarian hyperstimulation syndrome, you should continue until the end of the first trimester. And be careful that there is recorded cases of thromboembolism after complete recovery from ovarian hyperstimulation syndrome. And be careful also that thrombosis is not for venous system. It may occur for arterial system and affecting the upper part of the body and associated with symptoms like neck pain, dizziness, and the consciousness disturbance. women may present with thromboembolism several weeks after apparent resolution of ovarian hyperstimulation syndrome, as I mentioned before. If thrombosis is suspected, then therapeutic anticoagulation should be inside. So you should start another dose, because prophylactic dose, like 5,000 heparin subcutaneous every 12 hours, this is for prophylaxis, not for management of thromboembolism. When you start, if there is suspicious thromboembolism, you should start the high dose therapeutic one or anticoagulant. And of course, hematologist should share in the management of the case. Is there is rule for surgical management? Yes, for complication, and this is very critical cases, like this picture, torsion of adnexy. We know that the both ovaries are enlarged due to multiple follicles in cyst, so liable for torsion, so need laparoscopic untwist if they are still healthy. If they are ischemic and necrotic, there may be need for self-injectome and oophorectomy. But if still healthy tissue, just do untwist with laparoscope. Also, you may need surgery for ovarian cyst rupture and internal hemorrhage. And also, this is a very critical case, and they need experienced gynecologist to do this surgery. Also, ectopic pregnancy is another indication for surgery. Anesthesia is very important in such cases, and anesthetist should be experienced about the pathophysiology of ovarian hyperstimulation syndrome. Is there any risk with pregnancy in a case past the ovarian hyperstimulation syndrome? Yes, pregnancy is more liable to be preterm delivery, and preeclampsia may occur more frequent than normal cases. How to prevent ovarian hyperstimulation syndrome? This is a very important question. The key to prevent are experience with ovulation induction therapy and the recognition risk factor for ovarian hyperstimulation syndrome. We should know that ovulation induction regimen should be highly individualized. What is suitable for one case is not suitable for the other. And you should know the risk factors like PCOS. Take care about cases with PCOS, for example. Carefully monitor and use the minimum dose and the duration of gonadotropin therapy necessary to achieve the therapeutic goal. So you have a target to reach stimulation of the ovary. Try it by smallest dose and shortest duration. Caution is indicated when any of the following happen: rapidly rising serum estradiol, estradiol concentration in excess of 2,500 picogram per milli, large number of intermediate sized follicles from 10 to 14 millimeter, as in this picture. So take it serious. Withholding further gonadotropin stimulation and delaying HCG administration until estradiol level plateau or decrease significantly can reduce the risk of ovarian hyperstimulation syndrome. Available evidence suggests that casting doesn't adversely affect outcome in IVF cycle unless it is prolonged more than 3 days. Given the evidence suggesting that HCG may play a pivotal role in the development of ovarian hyperstimulation syndrome, a lower dose of HCG, which is a 5,000 international unit, is much better than the larger dose 10,000 international unit. in high-risk cases with ovarian hyperstimulation syndrome. GnRH agonist like leuprolide 0.5 milligram up to 1 milligram subcutaneous. Rather than HCG might be used to stimulate endogenous LH surge to promote final oocyte maturation and induce ovulation. This approach would be useful only in cycles not involving previous downregulation with longer-term agonist treatment or use of GnRH antagonist. Okay? Regardless whether HCG or GnRH agonist is administered at mid-cycle, the use of exogenous progesterone 50 milligram intramuscular or 100 milligram progesterone vaginal suppository or 8% progesterone vaginal gel daily for luteal phase support is much better than giving supplemental doses of HCG and reduce risk of ovarian hyperstimulation syndrome. Take care about this. Don't support the luteal phase with HCG. Please support it with progesterone, much better, and avoid the risk of ovarian hyperstimulation syndrome. When symptoms of ovarian hyperstimulation syndrome emerge, even before administration of HCG, cycle cancellation and the less aggressive stimulation in subsequent cycle should be seriously considered. Although evidence indicates that meticulous follicle aspiration will reduce corpus luteum progesterone production, it cannot be relied on to prevent the development or progression of ovarian hyperstimulation syndrome in ART cycles. Prophylactic intravenous administration of 25% albumin in a dose of 20 to 50 gram at the time of oocyte retrieval have been suggested as a means to reduce risk of ovarian hyperstimulation syndrome when estradiol levels are markedly elevated or there is history of previous episode of ovarian hyperstimulation syndrome. So if you know from the history that this patient has before an episode of ovarian hyperstimulation syndrome or estradiol levels are markedly elevated and you are going to do retrieval, please give the patient prophylactic intravenous albumin 25%, dose 20 to 50 gram. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.